psychiatrists rapping about our lives and work.
This podcast is not intended to be medical advice. Any stories we use have been altered to protect identities and sensitive information.
This is intended for entertainment purposes only.
You know it!
Ow!
Welcome to The Good Shrinks. We're glad to have you back today.
We're ready to talk it out with you guys about our jobs, our lives, and everything in between.
Yeah, this is a nice, safe place for us to go and kind of process what we go through.
Yeah, and I think this will be the one time we'll just suggest if you like this podcast, please like and subscribe to it, share it with a friend. We will have an Instagram handle, The Good Shrinks. So if you have any input on directions we should go, things you like or dislike about the podcast, feel free to send us a message.
Yeah, if there's something you want to hear more about or get into more detail, we are welcome to hearing from you. How was your week this week, Steve?
It's been pretty good. I've worked a good bit. I've had a lot of time with learners, like medical students and residents. Enjoy doing that from time to time, helping bring other people along the journey.
It's very noble.
Yeah.
Of you.
It's noble, but also it's like I try to make sure I leave out any of my jadedness.
Right. It gives us a chance to be really like the best that we can be.
Like the best version of ourselves.
Yes, because we're trying to instill on these new students, not new because they're usually, they've been through medical school and maybe towards the latter part of their residency, so they know the drill. And it's kind of a way to pay it forward, like the things that we learned along the way. We get to give those little nuggets to them.
Yeah, absolutely. It also kind of revitalizes you in a way because you see how like analytical and like kind of matter of fact they are about things. And in a way, it's a little bit endearing kind of seeing it's almost like a child in a sense.
They're learning like what kind of
Yeah.
doctor they're going to be.
Mm-hmm.
And also it's a little nostalgic for me,
Yeah.
remembering those experiences going through residency, how nervous I would be to make sure I had all my ducks in a row. But yeah, it's a little nostalgic. It's sweet. Traditional. It's like a tradition that you do.
Yeah. How was your week, T?
It was a challenging week. It was very busy at work. So some of the things that we do are in person in the emergency room. But then sometimes our shifts are remote. We do things by telepsychiatry, we call it. So I was working remotely this week, and it was super busy. And a lot of our colleagues are out with these respiratory viruses that are going around. So just felt like a lot of pressure to get people seen in just a little bit of time, and it was busy.
Yeah.
But I got it done.
Well,
I saw like 8 people on Friday, which is pretty.
That's impressive. Yeah.
Especially for me. I'm usually in the 4 to 5 range,
Yeah.
depending on the complexity of the cases.
Yeah, absolutely. So you were really hustling.
I
then,
was
huh?
rolling. I was rolling. It was good. It was like one of those where, everything, all the cylinders were firing, the ability to do chat with the doctors and nurses in the emergency rooms. That's a new feature that we didn't have before with our old medical record system. But we're able to do that now, so you can get questions answered quicker. You can get patient care delivered faster. It's a useful tool.
We have quite a bit of strain when it comes to maintaining being fully staffed, having other physicians with us. Like we are really kind of stretched thin sometimes. Right now, like the respiratory viruses are at like all-time highs. Like COVID is very, very rampant in the community, influenza. And so when we're down 1 or 2 physicians,
That's flu, by the way.
Yeah. The flu. But yeah, that really like puts a strain on us, right? Because then we really are taking on a lot more cases. Mm-hmm. And just so people know, to get some idea of like kind of who we are, I think in the emergency department, T's kind of like mother in the emergency department.
Really?
You come in very calm. You have such a calm presence. All the other providers see that.
Aww.
And I think it's like very lends to an open ear. And so it's just nice. Like, not saying, well, maybe other people have a little bit more of a chaotic vibe, okay? But
we are naming no names.
No names. But that is
to protect the innocent.
And so, I guess everyone out there, right, in their workplace, they have different
we all have different energy.
Yeah,
we have different energy. I appreciate that.
Yeah.
See, I had no idea people saw me in that role. You just come in and do your work, and you try to have good energy, because that is a chaotic place, and we need each other.
Yeah.
And if we're all flying off at the handle, then what kind of help are we to anybody else?
Yeah, we have to keep a conducive work environment. I think like as a whole, like we really do that with our colleagues. You know, we have like a pretty good group.
We're soldiers.
Yeah.
We are soldiers out there trying to help people get together.
Yeah.
Keep ourselves together.
And so here you say you saw 8 patients. Like, I know you're very thorough, and I know that was, people were like, oh, well, that doesn't sound like too much. I mean, that is of new consults and new patients. That's a lot. That means you're talking.
Because it's an 8-hour shift.
Yes.
So basically you're seeing people in, and you want to have at least an hour to kind of talk to them, do the note. First of all, figure out what you're going to do.
Yeah.
You have to think. People, you have to think about what you're seeing and how you can help. And sometimes you can and sometimes you can't. There was one gentleman I talked to, an older gentleman. He was so angry. So angry.
Don't you love that when they just come in hot? You're
And not angry like he was manic or angry like he was in a psychotic rage. He was angry at society and choices that he made to care for people who could not give him back what he needed. So, and he's now in his almost 70s, late 70s, and he's angry about all the time he put into those things, and he sees it as a waste. And so, a lot of times our job is just to kind of give perspective. First of all, allow him to feel what he feels, because these are valid feelings. Don't dismiss them, but then you want to give them some perspective, some hope, some alternatives to what they're thinking now. And so we just talked about what things he would like to do. And he's like, I don't want to do anything. And he told me about a place that he would like to go. Finally, he kind of thought about it and thought of it. And I was like, well, so let's make a plan. I mean, that's something we can talk about. Let's make a plan to go to this place where it's like a pilgrimage. You can go and really give respect to this thing that you love. And you might meet people along the way that also share your love for this particular situation. And he's like, well, I guess you're right. Like at the end, he just kind of crumbled into this, because somebody was listening to him. Like I was saying, it's just important sometimes that people know you're there.
Yeah, he was probably angry. No one's paying attention to him and listening to him.
He said that. I'm being ignored. That's what he was, railing against.
Yeah. And really, like, at that age, too, I mean, that's so, you're so reflective on your life at that time, And so that's, you kind of look back and see what you've done, and clearly he's not happy with some of the choices that he's made.
But to come face to face with that realization is really hard. You would rather blame everybody else for what the problems are in your life than to stop and take a mirror and look and say, well, what did I do to contribute to this? So that's hard. That's part of what we do, is kind of hold up these mirrors, and people are sometimes receptive, sometimes ready, and then sometimes people are not.
Yeah.
Or they will break the mirror, they will just completely, not want to deal with it.
Yeah.
They're just not ready.
I mean, kind of like maybe on a lighter, I don't know if funnier note's the word, but it's always interesting to me when someone's 80 plus and they come in with suicidal ideation. I mean, I always take everything seriously, but in the back of my mind, I'm just like, you're barely hanging on. How much life do you have left, and you really want to finish this?
I mean, ride it out. You got
right. You made it this far. What are we doing now? And
but at the same time, you're listening to all of that. I mean, sometimes people just, feel like they just come to confession.
Yeah, and it's sad.
And that helps them get those things off. Confession is good for the soul.
Yeah.
And kind of speaking of confession and
Bringing out your maybe biggest insecurities or your biggest concerns in the moment, kind of in psychiatry and even where we work, our bread and butter is depression and anxiety.
Yes, we do see that the most. In fact, anxiety is probably the most common reason people come to any emergency room setting. They think they're dying. They're having physical symptoms. And so, again, people are often amazed that we can connect those two things. But that is what, your brain is part of your body. And your brain is very powerful, can project all of these physical symptoms as a manifestation of their psychiatric illness. So you're depressed, you feel like you have no energy.
Yeah.
You're tired, you're lethargic. And that's physical. And with anxiety, people are having palpitations and chest pain and pressure. Those are physical symptoms.
I mean, I think maybe for the lay audience, like we should maybe describe depression to some degree and what we consider to be depression, and even kind of the symptoms together. Maybe once people hear them, they may still wonder, like, what does that even mean, right? The DSM, or like the standard diagnoses of depression, right? You have feelings of sadness for greater than 2 weeks. You have what's called neurovegetative symptoms, which just means things like sleep, so you're not sleeping. You have a reduced appetite. Your focus and concentration may be down. You may have pervasive feelings of guilt. And then when that becomes extreme, you may have thoughts of harm to yourself. That's kind of like the general idea of depression, and maybe some feelings of hopelessness and worthlessness. I think in the emergency department too, like we kind of come around and then we hear many individuals from all walks of life expressing this. And honestly, the mixture of presentations and why they all have these similar symptoms is so different, right?
Right.
It could be family conflict. I mean, it could be that they've lost a job. Sometimes it can seem almost biological, like you're not really giving me anything of why this may be happening. Like, how do you, in general, for you, when you treat depression, like when you first walk into the room, do you have a certain notion of what you expect, or do you just kind of go in open-minded and kind of see what happens?
Oh yeah, always the latter, because you don't know what you're going to get, and sometimes if you go in with a preconceived notion of what's happening, you may miss important things or questions to ask, because somebody comes in. First thing I do, I ask them, I introduce myself. Yeah. I ask them in their own words to tell me why they came today. And you sort of get a flavor immediately of which direction to go based on their answers to those questions. If it's somebody who's severely depressed, they may not answer at all. They may just be staring off, When we look at a mental status exam, that's sort of our physical exam compared to what other doctors do. We're looking at their appearance. We're looking at how they speak and what they talk about. We're looking at the expressions on their faces. That gives us clues as to what we might be working with. So people who are depressed tend to be what we call flat, which is like they don't have very much emotion in their face at all. They may be crying. That's another indication of sadness. They may have a disheveled or kind of unkempt appearance because they're not bathing, they're not taking care of their daily activities. So all of these things are clues that we might get that maybe depression is going on. And so we tend to ask more questions in that direction. So I might ask questions about their interest in things, because we know with depression, people can be either sad or lose interest in most things in their life. Some people who are depressed are not sad, they just don't care about things. So we ask about their interest. What have you noticed that maybe some hobbies that you have, are you still interested in doing those things?
Oh, yeah.
And people will say yes or no. We ask these questions to gather whether they meet criteria, or when you look at the DSM, for those of you who might not be familiar with it, it's a book that has this constellation of symptoms people could have to meet criteria for certain psychiatric disorders. So for depression, there's several different symptoms. Dr. C just laid out most of them for you. So we just ask those questions. If they meet criteria, if they tick off all those boxes, then we can say that they have a major depression. Sometimes people don't tick off all those boxes, and so depression has lots of different flavors. Sometimes it's just an adjustment disorder. They've just gone through a big stressor and they've been down for a few days. They don't meet full criteria for that. So based on the answers to those questions, then we kind of get in our minds, is this somebody that could respond to medication? Is this somebody that has such a safety concern, we just want to put them in the hospital to be safe? Is this somebody that can go home with a family member or friend to kind of watch over them? Are we able to get them some outpatient follow-up? So those are some of the things that we're thinking about when we evaluate people in the emergency room.
In our minds in residency, like going in, you're like, I'm going to treat everyone's depression. And you're like, well, I'll give them this tablet or this capsule, and hopefully it'll help with some of their symptoms. People tend to be a lot more complex. I think we rarely see something that simple. Like we kind of see people when they've had multiple medication trials, right? They've been in therapy, they have a lot of life stressors.
that can be a lot harder, I feel, to navigate. T, for you, like, you know, when you walk into the room and someone says like, oh, I've been depressed since I can remember, my entire life. Like, when you first hear that, you know, for you, are you like, oh man, here we go? Or no?
I say, but how long has this episode been going on?
Fair, yeah.
Because, you know, time. You got to kind of cut to the chase. Like, what's going on today? What made you walk into the emergency room today? If you felt this way your whole life, what happened today that made such a difference? What made it worse?
Yeah, that's true. It's kind of like there has to be usually an acute stressor that will exacerbate symptoms.
Sometimes there's not. Sometimes they just want to talk about how long they've been depressed. But sometimes you can get at what was happening today. But what about anxiety? We see a lot of that too. What does anxiety look like for you, C?
For anxiety, typically when I see patients, like they're, you know, kind of at their peak of anxiety, they can be very tremulous, you know, they express a lot of nervousness, just general feeling of a lot of worry. They often can have anxiety attacks or almost panic attacks.
What's that look like? What's a panic attack?
When we see that, they're often...
I'm putting you on the spot.
No, that's fine. That's fine. They're often like, you know, will complain of like racing heart, right? They can have sweating. They could have whole body tremor or a little chest tightness, shortness of breath, nausea. So it can usually last for 30 seconds to a few minutes.
But feels like
hours.
Forever.
Yeah. And some individuals will say like it wakes them up from sleep. So to me, that's like, okay, like there's something more. You know, the panic attacks are pretty severe, and I mean, it feels like impending doom. Like you're gonna die in a sense.
You're having a heart attack.
And I've seen that so many young individuals that have gone to several like medical emergency departments, complaining of heart attack.
Convinced
they're having a heart attack.
Because it's feeling like they are. Your brain is so powerful. It can just create these feelings. And I sort of see anxiety as like a bell. It's a bell ringing, sort of a non-specific bell, but it's telling you to pay attention to something.
Yeah.
And so if that's the start of somebody coming to the emergency room, their first experience, you really want to help them get to somebody that can help them figure out why that bell is ringing.
Yeah. You know, when it comes to treatment of those sort of things, like even with first episode of depression, if it's a one episode occurrence, like usually it'll dissipate within 6 months, typically, even untreated.
But, you know, anxiety, it's like those folks come in, they want to be treated now because it's so uncomfortable. Yeah, it's so disruptive in their lives. And so I think we do probably see more of the anxiety attacks and whatnot, like in the emergency department kind of front line.
I mean, I have had a panic attack. I did not know what it was at the time. I was driving across town to work and suddenly felt like my chest was going to explode. And I pulled over. Fortunately, I was able to pull over and did not know what was going on. And so I called 911 and they came and checked me out and they have these little portable rhythm strips is what they call it, where they can kind of look at the rhythm of your heart. And everything was fine. And I realized that there was something going on at work that I was really worried about. And so I sort of was able to work through it, but it is very scary when it happens.
Yeah.
And you don't know that it's a panic attack. You definitely should get checked out if you've never had one before and you have these funny feelings. Don't want to just assume it's a panic attack, but it's very amazing that it can mimic these very serious medical conditions.
Yeah, absolutely. You know, I'll be honest, I'll share. I've had one that disrupted me from sleep, and I'd never had one either. This was like a couple of years ago. You know, it was like actually pretty soon after a breakup, and then, I mean, my life seemed to be pretty much in order, and I was literally sleeping, woke up, like stood up out of bed because I just felt like something's wrong. Like I just felt like I was gonna like almost pass out, but I knew I wasn't. So I was just like walking around the room. I'm like, I don't know where my brain's at right now. Like that's what it felt like.
You get detached.
Yeah, you get so detached, and then I felt like my heart was racing, and it lasted about 30 seconds, and then I could tell it was dissipating. I'm like, I think I just had a panic attack, or it was a pulmonary embolism, one or the other. But, you know, being a man, I was like, I'm fine.
Going back to sleep now.
I'm going back to sleep. I'm going to give my male energy and power through this.
Meanwhile, rest in peace.
Yeah, I was never seen
Smash
again.
cut.
And it really could have been like my ex doing a seance. Who knows? There may have been a voodoo doll involved. Oh man,
hilarious.
I mean, really, because it was like I was like,
your brain tries to figure it out.
Yeah.
What is going on? Something is different.
100%. And I was like, and that was, I think I had one other minor one, and that was it. And I was like, I would never want this to happen again. And like for individuals,
but it gives you perspective.
Yeah,
and lets you relate to these people. I mean, we're humans.
So
humans go through stuff.
Things. And it does become relatable. I mean, after that, for like the next like couple of months, like if anyone came in with an anxiety attack, I was like so sympathetic. Like, I was like, oh my God. I was like, let me help you. Like
Can I get you anything?
Yeah, like what do you need? I was so much more like, just aware of the situation and kind of there what they're going through. So,
T, just wondering, so we both had our little lapses with anxiety. Have you ever felt like you'd had like a depressive episode, or?
Oh yeah.
You think so?
I don't know that it ever met criteria for major depression, and I'd never had thoughts of hurting myself, but I've definitely been depressed in my life.
Yeah.
Different things that you go through. Sometimes it's out of the blue, you know. Like we were saying, sometimes there's a definite stressor. What about you?
Well, I've never been depressed. I don't feel like I kind of lean towards depression, like just in general. Like I think I'm lucky from that standpoint, even genetically. But remember how like this 3-month span where like I was just like going through the motion and like, I mean, I was working out like as a millennial. I was on my Peloton trying to fight through it, and like I just felt like nothing was bringing me a lot of happiness, and it wasn't anything externally. And then I was like, maybe I'm like a little bit depressed, and it lasted like 2-3 months, and then it kind of dissipated. Again, I don't think I really met criteria. Like I was still able to function and work. It was just like I was a little bit more apathetic for like a couple of months.
Yeah.
And I just kind of felt like I was like a little bit more down. But I mean, would I say I had like a major depressive episode? I mean, I'm not really sure, but I felt like it was like one moment where I was like, maybe a little bit, And I don't think I had a necessary like stressor that attached to it.
See, so that's what I mean by that. These things have flavors. Like there can definitely be like what we probably see more of because we're in an emergency room. So just by definition, more serious cases come to us. Those people tend to meet criteria for major depression. The main thing is the duration, is sort of how we separate all these different flavors. So if you've been down or lost interest for 2 weeks or more, so, so we have like a day or two maybe where we feel like, bump it, I'm just going to stay in bed,
Yeah.
But if it goes on for 2 weeks, that's the point where we start to. And a lot of these criteria are what are used in research studies for these medications that we try. So there aren't a lot of necessarily good studies for people who only feel depressed for a day or two. Because sometimes people come in and they're like, this thing happened last week. I've been down all week. Should I start a medication because I don't want to feel like this anymore? And we can do that off-label.
Yeah.
And off-label means that we're using a medicine for something it wasn't researched for.
Yeah. Both like depression and anxiety are really like treated with the same medication for the most part, right? I mean, we're kind of describing depression, anxiety. I mean, the treatment side is a whole different avenue, and there's many different sort of treatment modalities, and a lot of it is kind of off-label, like you mentioned. Like it may be a medication for something else,
especially for children, because there are only a couple of medicines that are FDA approved, meaning that the studies support. But then you'll see children coming in on every other antidepressant that hasn't been studied or FDA supported. So there's a lot of off-label use of things for kids. Because imagine, are you going to sign your child up for some research study to study this new medicine and how it's going to affect them? There's not a lot of parents signing up for that study. Just like there are not a lot of pregnant people signing up for these studies. And so a lot of times when we have pregnant people who are depressed, we're also doing some off-label stuff.
Yeah, I mean, in some sense, like those, or the corporations that like make the medication, if it's already generic, I mean, they're not going to put the money into getting these studies for FDA approval, right? So it's like it's just sort of considered off-label, even though they're like many versions of SSRIs, right? But some may have one indication for one disorder versus another. So that's, it's kind of a whole different thing. And kind of thinking of treatment, like a first episode of depression can improve, spontaneously over a few months.
I mean, studies show if you have a second or third episode of depression, especially the third, at that point, it's like, I don't want to give it a specific, but it's pretty high. I think it's around like 90% that you're likely going to need an antidepressant for a longer period of time.
This is what I tell people when we're looking at medicines, is that the research shows the best treatment for depression and anxiety is some combination of medicine and therapy.
Yeah.
Some people just want to do therapy first. Some people just want to do medicines, and that's fine. The research shows that both together is the best. And I tell people to look at being on medicine for about 6 months to a year, not daily, but regular contact with your therapist and with your psychiatrist over that period of time. And then at the end of 6 months to a year, have a conversation about whether you feel like you want to continue the medicine or you stop. If you stop, another depression develops. I mean, some people never have a depression again. But if a depression comes back, then you're looking at 5 years to maybe the rest of your life on that medicine, because your body just may not make enough of that chemical. Like people who have diabetes, we tell them, they don't make enough insulin. You have to take insulin to make your body more efficient. And that's the same thing with serotonin, norepinephrine, dopamine, all these different chemicals that are involved in mood. Your body just may not be making enough of them. So this medicine helps to supplement that.
Making me think of like when I tell patients, in a sense, an antidepressant can be seen as like almost like a vitamin for your brain. Like it is increasing that serotonin, and it's just a pill you take every morning, and it can help with that difficulty that you're having. Like kind of the art for us is knowing how to tailor some of these medications to a patient, like depending on like their presentation, right? They have more difficulty with sleep, can tailor one medication in that direction. If it's more appetite, if they have, let's say, a background of headaches or migraines, or they have other chronic pain. So we really, do have kind of a way of sort of tailoring a medication to sort of help different ailments or comorbidities. So I think that's, someone may listen and say, well, if they're just going to prescribe a medication, like, why can't anyone do that, right? And there is like a pretty fine art with it. And I think like some of the newer interventions we use now, like TMS or transcranial magnetic stimulation, the ketamine, which is newer, it's shown to have an effectiveness for about 17 days. And so it is something that you do have to keep up with if you start. Ketamine, I don't know about UT, but there's kind of these boutique clinics popping up everywhere. The study's it's shown to be effective, right?
And
in treatment
rapid.
rapid.
That's the beauty of it. But
it
wears off.
I guess like
unfortunately.
It's just my own personal bias. It's like ketamine I know is used as a recreational drug. I don't know why. It's like my own just moral compass is like, is that something we should be prescribing for depression?
I think you look at the research, so definitely not like just going to the club and taking some ketamine and you're cured. No, it's definitely a professional, it's a clinic. There's like a nurse and doctors, and which is like with ECT, that's an older treatment for depression and all kinds of psychiatric disorders back in the 40s and 50s. Still depicted very negatively in social media and movies. It's very scary looking. But today's ECT is completely different. People are under anesthesia. You're actually in an operating room. You're in the hospital. Anesthesiologist.
You get muscle relaxers.
You
There's
are
no shaking.
Asleep. You're sedated. You're asleep. It's like you're going for a surgical procedure. It is probably the most effective treatment for depression out there without the potential side effects of medications.
Yeah, ECT, it's 80% response in treatment-resistant depression, which there's no medication we have that's high, which that's a whole different discussion is kind of the efficacy of some of the medications. But I do think like ECT does have a negative connotation in our society. There are movies that portray it very negatively, like One Flew Over the Cuckoo's Nest, or I think maybe Shutter Island, had a scene. And so you see these individuals that are like shaking, gritting, they're awake during a seizure. It is something that I think a lot of people are resistant to just because of like the portrayal of it on TV.
Right. So that's part of what we're doing, see, is just getting those misconceptions and myths out there to try to fight the stigma of treatment for mental illness.
Yeah. Besides just sort of the treatment, something else to talk about is depression is kind of a conglomerate of symptoms. Like we kind of mentioned early on, it's not necessarily one thing. I mean, are there other, from my perspective, there can be a lot of other reasons that someone can have depression or depressive-like symptoms.
Even individuals that, I mean, maybe the most obvious would be like bipolar disorder, right? Like they may just leaning more in depression. Typically someone with bipolar disorder, they may only have one manic episode a year or less.
You really kind of only see them when they are depressed. That's one possibility.
Another possibility is just like dysphoria or feeling down. I mean, individuals with a personality component may have more severity in that, which may bring them in.
Even individuals like with dementia, right? There's like apathy or less motivation.
So those people look like they're just a lot less interactive with their environment, and that can be mistaken for depression.
And then physical diseases like hypothyroidism, that often gets missed.
I think you're right with the medical side of things. I think people sort of
muscular sclerosis, there are lots of other physical.
People kind of dismiss like how much I don't say dismiss. I mean, we know how much we do and deal on the medical side of things. I mean, you're right. Hypothyroidism, autoimmune diseases, even cancer can cause depression
and anxiety.
Yeah.
Into life decisions, things like that.
Well, we don't have to go quite that. We don't go that dark, T, but we can stop at just the cancer.
I said it so matter-of-factly, too.
But I mean, cancer in itself, right? Some individuals that actually the release of the immune response causes dysphoria, and they are depressed clinically, but it's actually from like the immune response that they're experiencing, and so there's like an underlying basis for it.
Yeah, I was just thinking about I don't know if you remember that old game show. Is it What's My Name? 3 people come in, and all of them are telling a story about who they are, but 2 of them are lying.
Oh,
and it's your job to guess which one is telling the truth. What is the name of that?
Do you remember who led it?
I think Alan Ludden, wasn't he the guest host? And this was like back in the 50s or 60s. I think they made a remake later on, but this was the original game. With, they all dressed up. Some of them smoked there.
Those games were so cool back then.
Smoked there at the thing, way back. But anyway, I was just imagining as you were talking about that if you put people side by side, if you didn't know anything about their history, what would a depressed person with a medical illness causing the depression versus somebody with major depression, would they really look different? If you didn't have any collateral, if you didn't have any, could you tell the difference?
That's interesting.
That would be a cool game show.
That would,
guess my psychiatric illness.
By me just standing here.
That would be interesting. I mean, T, that might be your $1 million idea right there.
The winner gets cured. How about that?
Gets what cured?
Gets a cure for their illness.
I like it. Be like, you're now healed.
Yeah.
Boom.
But yeah, I think that is interesting. I mean, obviously it's context clues too, right? You do have to use like kind of your their entire background, the setting that they're in, information from family.
Yeah, all that stuff is those clues. We're detectives. We are asking questions to get answers to these things to give us clues as to what's going on with them. It's like a game show every day.
It is.
This is just to lighten our load. This is how we process kind of the heaviness that we go through sometimes with these cases. They're people in pain, and we're trying to help them best we can by getting all these clues.
Yeah. Well, speaking of media and psychiatry, do you have like a favorite movie that you think portrays mental health well?
Good Will Hunting, where there was just that relationship between the therapist and Matt Damon, Robin Williams and Matt Damon, and how they healed each other, in a lot of ways.
In the process.
At least in that movie.
Yeah.
It's an opportunity when we meet these people, you may go in thinking you're going to be the one that treats this person, but you never know when you kind of come away with a little deeper understanding of yourself.
Yeah, for sure.
What about you? Is there a movie that comes to mind?
I think for me, I just really like Girl Interrupted with Angelina Jolie and Winona Ryder.
Yeah.
I mean, I think Angelina Jolie does such a good job of portraying someone who's like kind of broken, a little bit antisocial, right? And, Winona Ryder does a great job also. I just really like the depiction of mental health like in that movie.
Yeah.
No, it's an oldie, but it's a goodie.
Yeah, it is.
Yeah.
It's a good one.
All right, T. Well,
see you next week.
Yeah, we'll talk to everyone next week. All right. Bye. Bye.